Good morning, and thank you for joining me today. I'm genuinely delighted to be here. I'm talking to you about something that merges my passions: health data, equitable care, and practical system level improvements. I am talking to you about diabetes, foot ulcers, and clinical care pathways. Let me begin by giving you a quick window into who I am. My name is Dr. Elisavet Andrikopoulou. I am a senior lecturer in computer science at the University of Portsmouth, and for the past several years, I've worked at the intersection of health informatics, digital systems, and patient empowerment. Before academia, I had a fairly unconventional journey, starting in law and then pivoting to computer science, database administration, IT consultancy, and ultimately I completed a PhD in health informatics. I've worked in several countries, including Greece, Belgium, Germany, and finally the UK. And this has deeply shaped my appreciation for diversity in care systems. I see research not as an end, but as a bridge between knowledge and action, between systems and the people they are meant to serve. Today's talk is all about building such bridges, especially in the realm of diabetic foot ulcer care within the NHS. So, why diabetes foot ulcers and why focus here? Well, diabetic foot ulcers are not just a complication, not one complication of diabetes as one of many. They're a warning sign that tells us something in our system is misfiring. They're incredibly costly, both financially and in terms of patient and family of that patient's suffering. They increase the risk of hospitalization, amputation, and even premature death. But perhaps, and most importantly, they are often preventable. And when they do occur, they reveal a lot about the cracks in the system, such as fragmented care, inequitable access, and inconsistent education. And that education is not always education about patient education, but also clinical education and clinicians' education too. When you look closely at how diabetic foot ulcers are handled, you don't just see the wounds, you see the systemic consequences of disjoint services, under-resourced teams, and populations left behind. To understand these issues more deeply, we designed a mixed method study. Our aim was not just to collect data, but to surface patterns, contradictions, and stories that could drive change. We want to identify potential areas for improving diabetic foot ulcer care delivery and patient-clinician engagement. We want to model the lived experiences of frontline healthcare professions in diabetes foot care and to show the interaction between their experiences and barriers to effective care and patient engagement. Therefore, we began with a nationwide survey of those NHS professionals working in diabetes foot care. 249 people responded, and they gave us a wide view of how care is delivered and experienced. Then we conducted 27 in-depth interviews with carefully selected participants from primary, community, and acute care settings. These interviews helped us to zoom in to understand the texture and emotion behind these statistics. Now, let's dive in into what we found. On the surface, many respondents reported that making referrals was straightforward. But when we disregarded the data, primary care professionals told a different story. Nearly 1/3 of them said referrals were difficult or inconsistent and not as straightforward as writing another letter. Data sharing was another sore spot. More than half of all participants across all settings said that accessing records from other services was hard. That means repeated tests, delayed decisions, and missed opportunities for an early intervention. And perhaps most concerning, only 1 in 5 of whom we asked believed that patients understood what standard of care they were entitled to. That tells us that we have a massive health literacy gap, one that compromises both prevention and outcomes. Is that because patients don't understand what they are entitled to? Or can we do something better? So, what the numbers suggested from the survey, the interviews confirmed. Pardon me. Clinicians spoke passionately, often with frustration, about the systemic barriers they encounter every day. So imagine a patient discharged from hospital after a serious food infection, and their GP are unable to access the hospital notes. So they have no idea what the hospital treated this patient, how they treated that patient, or what the follow-up aftercare needs to be. Community podiatrists may not even know the patient was even admitted in the hospital in the first place, unless the patient is kind enough to tell them about it. Everyone's working in good faith that the patient will actually let them know, or they are capable to let them know, or they remember, or even they speak English well enough to let them know. But their systems are siloed. One participant called it digital chaos. Another theme was delays. Referrals to vascular or orthopedic services could take weeks, by which time the condition had worsened significantly, sometimes ending in amputation, which initially could have been prevented or might have. These are not just clinical failures, they are failures of infrastructure, a systemic failure. Following to that, many participants pointed to the disproportionate burden faced by people in socioeconomically deprived areas. Lack of access to transport, unstable housing, inability to afford dressings, clean water, these factors deeply influence care outcomes. There are patients who are unable to even afford the electricity to keep their medication in the fridge. For patients who are elderly, isolated, or facing language barriers, the healthcare journey becomes even harder. Several clinicians shared stories of patients missing appointments because they couldn't afford to travel or they couldn't leave work. Others described families acting as both caregivers, also gatekeepers, sometimes reinforcing mistrust of professional advice. And when you compound all of these barriers, it's very easy to see why outcomes vary so starkly and why equity must be central to our solutions. If there was just one message that resonated throughout our interviews, it was that clinicians are doing their best, often in very challenging conditions. Many clinicians expressed compassion and commitment. Many clinicians described going above and beyond to fill in gaps in care. However, many of them also voiced exhaustion and a sense of being let down by the system. They wish they have tools that they worked, referrals that they don't bounce back, and training that prepares them for the diversity of their communities. One clinician said, I don't need more guidelines. However, what I need is support to follow the ones we have. So, what do clinicians or professionals want? What's encouraging is that clinicians weren't just identifying problems, they were also offering solutions. What they want is simplified, standardized referral processes that don't vary widely by region or department. They want digital records that can be accessed across settings, what one called a single source of truth. Some clinicians were volunteered that they had to log in to 3 or 4 different systems with 3 or 4 different passwords at a time. Needless to say, some of them are not as digitally competent as others to remember 4 or 5 different passwords. So they used the same password in all the systems or different passwords that they were writing them down. And then if one system was unable, they were unable to access one system, then they couldn't assess the patient coherently or appropriately. That meant that they couldn't see a set of results, clinical results for one patient. Then they wouldn't be able to write the referral appropriately. And that cascades to further delays or further mistrust from the family or for the patient. So they wanted standardized and unified digital records. Other clinicians pushed for culturally competent education programs, not just for patients, but also for clinicians. Because some areas of the world, they don't see certain cultures or people from certain cultures, that do not mean that we forget certain conditions exist. However, this is the truth behind it. Importantly, clinicians emphasize the value of involving family members and carers in care planning because standards say that something works, a treatment might not work for everybody. It's not about being efficient, it's about being human. It's about listening. So, what does a better system would look like? It might look like care teams that can see the same patient record, no matter their location or specialty. It looks like referrals that they are quick, accepted and tracked. It looks like patients and families understand their conditions and feel empowered and not intimidated by the care process. It looks like patients and families who understand their care process, that they engage with it, and they are not abandoned by it. And it looks like education that reflects the real diversity of our communities, not a one-size-fits-all approach. It means designing with equity as a default, not an afterthought. It means listening to what people need from the bottom up, from the design, not as an afterthought, not when the solution is already in place, but when the solution is in the infancy, is at the beginning. Now here is the part where I ask something of you. If you're a researcher, make your findings visible to the people who can act on them. Don't hide them. And if you're a technologist, build systems that they are not only secure and fast, but interoperable and intuitive. Everybody talks about interoperability, and very few people actually act on it. It's not as trendy interoperability as AI is. And if you're a policymaker, invest in education and equity, not as side project, but as central priorities. If you're a clinician, your voice matters. Share your insights, collaborate, challenge the status quo. Because I've heard from the clinicians a number of times, oh, this program doesn't work, this software doesn't work, but what can I do? But if you don't do something, who does? Change doesn't happen in silos. Change needs to start from us. If we design systems that only work for the average patient, we exclude the most vulnerable by default. And these are the patients that need us the most. These are the people that they don't have a voice by default. Equity is not something to layer on top. It's the core architecture of effective care. Diabetic foot care, for many, is a narrow topic. However, it can be a template for reflection. And as we've seen, it can reflect much broader truths about our healthcare system. If we can fix diabetic foot care pathways, who tells us that we cannot fix much more? If we can start fixing a pathway on a narrow topic, why not take the lessons learned and fix the pathways on a broader topic? So thank you very much for your time, your attention, and your dedication to better care. I would very much love to stay in touch, and I would be very much happy to talk to you further about the journey towards equitable integrated care. I know that equitable integrated care, interoperable data is not going to be easy, and the journey towards it, it's very long, but I would be happy to take one step at a time and to walk on this road with you. Let's keep this conversation going, and let's discuss together. Thank you very much for listening, and thank you very much for inviting me for this keynote.